Okay, part two. The paste, it's like toothpaste, but it's thicker. And where the stoma is sticking out, like this, you take the lid off and you squeeze it, and you go all the way around, and you make a one solid line of this paste. And then when you go to put this bag on, it kind of flattens that paste out, and it protects that skin right around that stoma. The important thing is you don't want that stool or urine, when it comes out, to come out, go down along the side, and then get on the skin. You got to keep it off of the external skin. It's not set up to handle the pH of urine and stool. The pH of stool, the pH of your skin is 7. The pH of urine is like 5, 6. The pH of stool is 2. So the difference between 7 and 2 and 7 and 6 is a lot greater. Stool on someone's skin, it'll just burn it. It'll eat a hole through it. So it's really important to keep it off. The other thing that we use, that's right around the stoma. The other thing that we use is called Sure Prep or Skin Prep. They're protective wipes. It's like an alcohol pad. You open it up. Everywhere where this tape is, except for that inner circle there where the paste goes, you wipe this and then you let it dry. And it puts a film layer, like a plastic layer, over your skin so that when you put the tape on it, it sticks to the plastic layer, doesn't stick to the skin. It's really nice. I love it. Used it a lot. Works great. That one there is used for the stool. This one here is used for the urine, and all it is a stopcock valve where you turn it this way, it's red, watch out, the urine's coming, and when you turn it that way, it stops. Okay, next in the goodie box. This is just a face mask. You know, the nasal cannula that I showed you. Most patients don't like these though because they're restricting. It just feels kind of claustrophobic when you have it on. It really does. It's hard to breathe. But you do get a higher oxygen percentage. Nasal cannula, you're getting like 20 to 30%. When you put this on, you can get like 40 to 50% oxygen. So if the patient's lungs are that poor, they'll switch them over to this type of a mask so that they're getting more oxygen. I did want to show you this here on the end. It just pulls apart. This is threaded, and on the oxygen machine itself, when it comes out, this will be attached. It'll just be hanging there. This is called the Christmas tree because it looks like a Christmas tree put it like that. And it's important that you never throw this away either, because this is one of the important connections there in the house. If the patient had this and didn't have the humidification, this is how you would connect the tubing to the oxygen machine, the Christmas tree. Okay. This here is called a Yankar suction catheter, Y-A-N-K-A-R. It's hooked up to a portable machine. It also has an on-off button that plugs in. This is for patients that have secretions in their mouth, or maybe they choke a lot when they're eating, they cough a lot. Similar to what they use in the dentist office. The important thing to note is there's a hole right here. Right there with my finger. I'll pass it around so you can look at that. But if you were to put this down into a container of water and not put your finger over the hole, it wouldn't suck. So the only time that it'll suck to create the negative pressure is put your finger over that hole, and that's when it sucks. You don't want to use this in someone's mouth for longer than 10, 15 seconds. You know, you just sit there and don't breathe. And tell me how long you're comfortable. Okay, because when you put this in someone's mouth, you're just sucking the air and the oxygen out of that area where they would normally breathe. So you want to be very careful that you don't use this for longer than 10 to 15 seconds at a time. And always, 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 after you use it in the patient's mouth on the sides, you can use it in the middle a little bit, but if you get back too far, you're going to trigger their gag reflex, and you're going to make them throw up on you. So don't do that. Normally, stick to the sides. Always put it in water when you're done. Just dip it down in water. And that'll clean the tubing out and the tubing that connects to the machine. If not, that saliva that you're getting out of there and it's in there, it'll crust and it'll harden and it'll clog your tube off. So then, in a week or so, you're going to have to throw this away and go get another one because it's shot, because you didn't clean it. So it's real simple. After you use it, put it down and dip it in some water. It'll suck it right through. The canister that goes into, there's a Tupperware container is all it is. You just pop the top off, empty the contents, rinse it out, put it back on, and you secure the lid back on the Tupperware container. Don't let it get more than about half full, because if the fluid were to go up and go into the machine, you could blow up the machine, and then it wouldn't work. So the actual liquid that you get out and your rinse liquid that goes into that machine, only about half full, and then empty it. We'll show you this stuff here, but if you're in a home, we're going to show you again. So don't worry if you don't remember something by then. Next is specimen container. The visiting nurses may leave one of these at the house for you to get a sample, either a stool sample, a urine sample, or a sputum sample. If it's a sputum sample, you take the lid off, you don't touch the inside, and if you ever set the lid down, you set it so that the clean side is facing up, the side that you didn't touch. So then you pick it back up, put it back on. That way your bacteria on your hands aren't inside of the cup, just the specimen. So you set the lid like this, sputum culture, patient spits in it, put the lid back on. You want to put the patient's name and the date, and then always put it in a Ziploc bag, put it in the fridge, no matter what specimen it is, because that will, refrigerating it will slow down that bacterial growth rate. If it's a stool culture, the patient uses a bathroom, either in a diaper or in a bedpan, then you have to take, like a popsicle stick and put a specimen in it. Again, put the lid on, put a Ziploc bag, put it in the fridge. Make sure you have your gloves on. Urine sample. The patient starts to urinate. You don't want that. Wait until they start to urinate. And then halfway through, then you put this underneath to catch the specimen. You got to get at least an ounce. They really like 2 ounces, which is about half of this cup. I have sent specimens less than an ounce, and they rejected it. You got to have at least an ounce to do the testing. So that's important. But you want a midstream specimen. You don't wait till the end and then stick it under, and you don't catch the first that comes out. You do a midstream. And then, same thing. Put it in a Ziploc bag, put it in the fridge. Go wash your hands. It's that simple. Make sure you label it with the patient's name and date at the time. Normally the nurse will leave you a label there to stick on it. Okay, simple wound care. Michelle has an open area. Tammy has an open area. I give you 2 minutes. And we're going to take just simple wound care. I'm going to show you how to cleanse it and how to wrap it. When you open up your pads, this is a 4x4, you're going to keep one on one side, one on the other. And to do that, you have to separate them. And you don't want to touch the inside of the pads. I'll show you how to pick them up when we get to that point. We take our saline. We've got our gloves on. I have them here. I'll put them on. We've already rinsed our hands. We're being good home health aides today. Okay. We take our saline and we put it in the center, about the size of a quarter or 50-cent piece. We touch the corners. Now we're using clean technique. It's not sterile. These aren't sterile gloves, but they're clean. She has an area right here on the middle of her forearm. We're going to take this and clean it. We're going to start in the center, and we're going to go in a circle from the inside to the outside, and we're dragging bacteria away from the wound itself.
Okay. Oh, I know that. Okay.
We take this dry pad to dry it, and we do the same thing. Push down in the center,
Right.
and gently
Is there a mess there?
go in a circle, inside out. Now we've just cleansed the wound from bacteria.
Do you want to go to the hospital until Jerry shows
We take our, in this situation, we use a Telfa pad,
you? Really want to try to get hold of him? So
sterile Q-tips,
Yeah, go ahead and lock the door and go head up there. And
our triple antibiotic
call
cream.
me when you leave there, as soon as he comes.
over the counter.
Okay, just so she's not by herself. Okay? And then
Remember, always set the lids up when you take things off, you'll notice. We take our Q-tip and we go ahead and apply
Okay, honey.
the medicine to the wound itself. Again, by touching the corners, we take our Telfa pad
Right,
and put it over the wound.
right.
If the wound's draining a lot, the nurse will tell you to take another sponge and put over top of that pad there. But if it's not draining a lot, all you need is just a Telfa. And the Telfa is wonderful. It's like the non-stick Band-Aids that they have.
Okay, honey.
That way, whenever I go to change that and I go to take it off,
Right,
if I had only put this gauze sponge on it, see how coarse that is?
All right, honey, like I said, go ahead.
This is going to attach itself to the wound bed, and you have what's called epithelialization.
That's fine.
The
Just walk
new
out.
cells that are growing there, that are trying to heal that, every time I take this off, it's going to rip all those new cells off. Keep ripping it off, ripping it off. It's not going to heal. You want to leave those good new cells there that are trying to heal. This is called roll gauze. I like to use it because when you go to put tape on, you can pick it up for me. Unless it come over by me. I didn't see it. When you go to put tape on it, and most of these older people, their skin, you got to be very careful putting tape on it because when you go take tape off, you're going to take their skin with it. But to use the roll gauze, always start furthest away and you roll up toward the patient. You take it around one time and it locks itself. You continue to go around, covering about half. See, if you look at the distance of this and then where this one hitting, it's hitting halfway in between the one before it. And if you didn't want to use the rest of this, you could cut it off. But for purposes of class here. Okay, now at the end, to get it to where you need it to be to put the tape on, you could fold that over or you could cut it off. Then you would take your tape and you would tape it right there to itself, and that would stay. If you have a problem with it sliding, this is some nice stretchy stuff. Can't remember the name of it offhand. It'll come to me later. We'll stick your hand in. It's not Kerlix, but it's similar. That will help keep that dressing in place. That comes in about 10 different sizes. I mean, they have it for your trunk that goes around your body where you can cut, make little cuts and the arm will go through and another cut, head goes through. If someone has an injury on their hand, I had put a little hole in this one where if you're bandaging something up on the wrist, you can put a hole in it and stick your fingers through and it will still hold it real good. Okay? When you're going to take a dressing off, wash your hands, put your gloves on. Start by removing the outer layer. If you're going to use scissors to take it off, you want to lift and cut. You want to lift on the dressing and then cut. Lift and cut. Lift and cut. Because even though these are safety scissors with a curve on it, I've seen family members that have went like this and dug into Grandma's ankle, and there's a big slit in Grandma's ankle. Okay, and then not only do we have the dressing on Grandma's heel, we now have the dressing we got to change on top of Grandma's ankle. So be careful with that. Lift and cut. Did I cut you? See that? It works. Okay.
Isn't that called mesh?
I believe.
Yeah,
Something like
that's
that.
what I was thinking.
There's a specific name for it. I can't remember. That's the only piece I have, though. So I'm keeping it. Okay, next I want to show you the Duoderm. Now, instead of putting the Telfa on, they may order Duoderm for a patient, especially if there's a pressure sore area. Hip, tailbone, heel. If the doctor orders that, I'm going to send this around for those of you that haven't seen it. It's real soft. Okay, we would cleanse the wound, take this out, we've got our gloves on, peel this off, and then stick it right onto the patient's skin. You want to push it and hold it for about 20 to 30 seconds. The heat from your hands and the pressure allows it to stick that much better. This will stay on anywhere from 3 to 7 days. And then what you do is you take your pen and you write the date on it. Okay, today was 4/25. And when it says change it once a week, and you're in the house and you look at it, oh, okay, that was changed on the 18th. Today's the 25th, I need to change it. But I want you to feel how soft it is. It's like adding an extra layer of skin to a patient to protect that skin. Now, if there's an opening under here, the opening, this will not stick to the opening. It only sticks to the skin surrounding the opening. And then the wounds, it's like a fake scab, essentially. There's that kind, and then there's this kind. If it's an area that that doesn't have to have that much protection on it, this is called SureSight. I've also heard it called ObSight, but it's clear. And the advantage to this is when you put this over a wound, you can still see the wound. So you can see if there's green drainage, or if it's red or swollen, or if it's bloody. You can see the fluid, the drainage, or the actual wound bed itself, and you can tell if there's a problem. It's clear. That's called SureSight.
So with this, there's no glue either,
Mm-hmm.
like you would with tape.
No, it's already an adhesive. Peel back and feel it. Now, what I would like to do is put some of that skin prep plastic stuff around the wound before I put that on. That'll protect that skin from the glue that's on that. It's an adhesive backing. Works very well. And if I was putting it on someone's heel, I would cut a V like this. In this corner and this corner. And when I peeled it off, I would put their foot right in here, bring this up, bring this forward, and bring it around the Achilles. And that's how you would put it over a heel wound. If it was on their tailbone, you can either put it on like this, diagonally, like a diamond, or you could cut it in a V, the small one, or they make these for the tailbone. Peel off the backing, put it on, nice and soft. And it's already that triangular shape. That would be a pretty big wound to put that one on. Normally you would just go ahead and trim this one down, because normally they're just small, the size of your thumb. That one there would be the size of your fist. I've seen them like that, but we just try to prevent it from getting that way. Okay, and that's the end of the goody stuff for now.